I have heard wonderful things about this program, and patient participation has been one of the most important parts about it. So I'm really happy to see such good participation, number one. And I would like to start with saying that in hematological settings, pain and symptoms related to either the cancer itself or due to the side effects of the treatment are often ignored, more so than they are in solid cancers. So and the other thing is that patients with lymphomas have a much better survival than some of the solid cancers. So it's very important that we manage pain and other symptoms that come with either the therapies or they come with the primary disease itself. So the hope with this presentation is that I can give you a basic idea about what a pain and palliative care specialist does for lymphoma-based illnesses and what treatments are available for various symptoms. So I work at the Rutgers Cancer Institute. We have a big palliative care department here, and I work on the outpatient side. So let's see if I can move this forward. Disclosures, none that are relevant to this presentation. So there is actually a list of the most common symptoms that patients with lymphoma have. And the most common one, again, is pain, number one, followed by nausea, followed by low appetite, followed by issues related to anxiety, depression, insomnia, and fatigue, which is almost a common theme for all the patients. Um, so I'll start. I'll just give about 5 to 10 minutes to each of these symptoms, and the hope is that we can finish in about 40 minutes or so. So I'll start with pain. So it's important to know how your clinician will treat the pain. If it's acute pain, this means that it's pain that has been less than 6 months. If it's chronic pain, the pain has been present for more than 6 months. And sometimes what we see in cancers is something called as acute on chronic pain, which is like someone has a baseline constant pain that is present. And then on top of it, they get these spikes, which make the pain much worse and very difficult to control. So for acute pain, usually what most physicians recommend is that you use simpler medications, some things that are over the counter. But often they are not an option for lymphoma patients. So sometimes opioids and narcotic pain medications can be used. For chronic pain, if the underlying cause is cancer based, opioids are a good resource. Narcotic medications are a good resource for pain management with good monitoring. And the same goes for acute on chronic pain. So it's very important when you go to your physician and they ask you, how long has the pain been there? You can say if it's less than 6 months or more than 6 months, because that may change the kind of treatment that you will get for that pain. So another thing that is really important here is something called as nerve pain. This is something that a lot of people get either sometimes they have diabetes or other illnesses which make the pain in the limbs, the hands and the feet, primarily in the toes and the fingers, which almost feels like tingling, electrical sensation with numbness. Often this is caused by the treatments that are given to cancer patients, and this can be persistent. It is very bad and very distressing in winter time. So it's very important that you let your physician know that, listen, I'm having this numbness and tingling and electrical burning sensation in my hands and it's bothering me. And when you have them in your feet, you may have difficulty balancing yourself, and that can lead to falling down, and that's never a good thing. Another factor that is really important is you should know what aggravates your pain. Patients with lymphoma go through a lot of difficult times. And sometimes there's anxiety, there's depression, there's stressors related to regular life. So that can aggravate pain. And that's a real phenomenon. So you should really talk to your physician and say, listen, this is a stressor for me. I think that I need better pain control because I expect XYZ to happen in the future, and that may be aggravating my pain. So don't deny the fact that just because pain is physical, psychological factors don't impair it or make it worse. So now let's go to what treatments do we have for pain. it's very important that whenever a patient has cancer-related pain, especially patients with lymphomas, we should always focus on treating the underlying cause. And in most cases, it's the cancer itself. So continuing the cancer therapies, continuing the chemotherapies, immunotherapies, CRTs, anything that you're getting, continue that. The second thing is that the easiest way of managing any kind of local pain, let's say someone sprains their arm, sprains their leg, is local treatment. That's always the first time because lymphoma patients are already on so many medications. There are interactions that we want to prevent. So my first line therapy for a simple pain issue related to a sprain, a ligament related pain, or something like tight muscles, I would always use local treatments that include local lidocaine creams, local NSAID cream, things that don't get absorbed deeper, local massages, essential oils. These things are really great, and actually they don't have a lot of side effects because they don't get systemically absorbed. Then you have the second line, which is over-the-counter treatments, over-the-counter aspirin, Advil, Motrin, ibuprofen, Aleve. You have over-the-counter treatments like mixtures of different medications. The issues with lymphoma patients at times are the fact that they're immunocompromised, and you cannot give them NSAIDs and you cannot give them over-the-counter medications. So it's really important that you run it by your clinician, especially your hematologist. Tell them that, listen, I'm having XYZ pain. I don't think I can take this pain medicine. What's the next line? So don't take all these medications because they may suppress infection signs and symptoms, and we don't want to do that. So other things that we can use are integrative options, massage, acupunctures. I get a lot of questions about medical marijuana. I mean, does it work? So the answer is, we all wish that it worked. When medical marijuana came on the scene about 5 to 7 years ago, we were all very interested as to, what potential does it hold in the world of pain management, especially for cancer pain patients. And we saw that work really well on social media, but when we put it on trial in real life and in research trials, we didn't find a lot of benefit. Yes, there is some benefit in certain nerve pain syndromes. There's certain benefit in nausea management, certain benefit in appetite stimulation, but it's very minimal. We all were hoping that it would be better. So the answer is medical marijuana is an option, but it's a sixth or seventh line option in most cases for cancer patients. Other pain treatments that we use commonly, especially for patients undergoing active treatments or active disease when they have it, is mild opioid or opioid-like medication. These can include tramadol. This can include different combination medications like hydrocodone, like previously we used to have Vicodin, now we have Percocets, now we have things like Norcos. Things can be used for that, for temporary purposes. Then if that doesn't work and the disease is getting worse, there are long-acting opioids like long-acting morphine, long-acting oxycodones, fentanyl patches, methadones. There are tons of options. But again, these are things that are better done by a pain or a palliative care physician. So definitely ask if you're having worsening symptoms. Ask your clinician, listen, can I have a palliative care physician see me? There's in most big cancer centers, there is a palliative care person or a pain person that is available to see patients with cancer-related pain and symptoms. We always screen as the guidelines have become more clear. Your physician may ask you, can I get a urine sample? Because that's what the state requires. They may give you things like nasal sprays to reverse opioid overdose if that ever were to happen at home. They may ask you different questions. They may ask you for a pain agreement. They may ask for pill count. So again, different states have different guidelines and different physicians and different practices follow it differently. So ask your physician what screening guidelines do they follow in their practice and in their state. Other options, there are injections. Sometimes you go to a pain physician, they'll give you an epidural. They will give you a nerve block. They'll give you an intramuscular injection. Sometimes there are intrathecal therapies like pain pumps and spinal cord stimulators. So ask about those things as well. If you don't want to give medications, the question that you should pose is, well, listen, I mean, I don't want to take a lot of pills, is there an option for an injection? Is that something that will be helpful? Because I don't want side effects. So your clinician should be able to refer you to someone who can do that. So what are the pearls? What does Yoda say about pain management, right? What are the take-home points for this? So as a physician and as when I'm working with someone as a pain patient who's having difficulty with cancer treatments and pain management at the same time, so we always set a goal of reduction of pain to tolerable levels. We always say that, listen, it may not be possible to get complete relief. Why? Because pain itself is something that comes from perception in the brain. And if we completely control the pain, we may completely knock out someone, we may completely sedate a patient. So our goal is to reduce it to a level where patients are functional, where they're able to do things that are important for them. Complete relief is often not something that we can promise or offer under the circumstances. We always start with the lowest dose. The idea is that we don't want a patient to get a side effect or sedation or very bad constipation and nausea and vomiting and everything else that comes with overdose of medication. So we start at the lowest doses and slowly go up. So that is something that we follow in pain management. It's very important that as often as you see your hematologist, you may need to see your palliative care physician or your pain physician as often. Frequent clinical visits are really important because cancer pain is not like something that is present continuously. It changes, it goes up and down. So doses and medications need to be changed. So frequent clinical visits, at times, I see my patients sometimes weekly, sometimes bi-weekly, every 2, 3 weeks. And the idea is that we want to be available and we want to change medications as often as needed. One prescription does not cover things. So there always needs to be tweaking, changing, altering, increasing or decreasing doses. So you may need to see your pain physician regularly. And this basically goes into the next point, which is communication. It is very important that you communicate well with your pain and palliative care physician. You tell them what your new symptoms are. You tell them what the new side effects are. You tell them how well you are tolerating pain medication. And it's equally as important, vice versa, for them to communicate with you about what side effects you will have, what symptoms you will have in certain time, and how you can manage them at home yourself. So that communication and frequent clinical visits, I think they go hand in hand. All right. So at this point, I'll move to the next symptom, which is the second most common symptom that we see in lymphoma patients, that is nausea. So nausea primarily is caused by treatment of the cancer in most cases, as far as the data and the statistics are concerned. There can be hundreds of other causes. And I will show this slide, just this little thing, that this is not something that is important for a patient to know to this detail, but this is something that has been documented in literature as to what the causes of nausea can be. The idea is not to give you like a bundle list of what can cause nausea, but to tell you that if your clinician asks you about certain symptoms and asks about, is your ear okay? Is your head hurting? Is your stomach hurting? All these things is because they are trying to rule out all the other causes that I put here. They want to rule these out and make sure that they're not missing anything, because nausea can be caused by hundreds, if not tens of hundreds of things. So chemotherapy is the most common one, and usually when chemotherapy is provided, they give you nausea medication. But if your nausea is persisting beyond that, then that needs to be worked out. So if your clinician says, listen, I want to get a upper GI endoscopy, that is because they're wondering if there's something happening in the GI system. If they say that, listen, I want you to see an ENT physician, it's because they're wondering if there's something wrong with the ear which is causing nausea. So that is where the questioning comes from. So from a patient standpoint, the question is, what are the do's and don'ts of nausea? So there are certain do's in oncological management, in hematological management, especially related to lymphomas, and they include when you're having your favorite foods, don't have them during times of nausea. Patients with cancer and lymphomas, they have difficulty eating food. They have difficulty maintaining their weight. So it's very important that your most favorite food is used at times when you actually feel like eating, right? If you're nauseous, you look at that food and you're like, I don't want it, right? So that will turn you off from that food for a long time, and you don't want that. You always want that go-to food at the very end. So avoid your favorite foods during time of nausea. Another one is that you should eat small amounts of food throughout the day, rather than three large meals. So how I tell these are my patients with lymphoma how to eat is that have an early breakfast around 7 a.m. if you wake up that early. Then have a late breakfast around 10 a.m. Right? Then have an early lunch, munch on something very small. You don't need to take like 500 calories. Something very small. Grab an apple, grab some yogurt, right? Have an early lunch. Have a late lunch around 2:30, 3 p.m., right? Grab something around, I would say, 4 or 5 p.m., something very small. And then have something else before going to bed. The idea is that instead of having three full meals, breakfast, lunch, dinner, sometimes patients with lymphoma are not able to take an entire plate of food. They need to have small little foods, high nutrition foods, and they can have them more frequent. And that way they can tolerate food better and get more caloric intake in them. The other thing that we say to patients is that patients who've been admitted, they know that dehydration is a big problem. So instead of having big gulps of water, sips of water, liquid, throughout the day. Get one of those bottles that has numbers on it, like says, oh, you've done like 300 ml, you've done 400 ml, 500 ml, you've done so many ounces in a day. So that you set a limit as to how many ounces you need, and you drink that amount in small sips. And that way you can keep account of how much you're drinking as well. Um, Cooled or chilled beverages are definitely better tolerated when someone has nausea. What we usually say is that if you like a certain drink, if you like a certain smoothie or a certain Coke or 7 Up or something like that, freeze it in an ice cube tray. You can suck on that cube. Try popsicles, try gelatin, something different, right? All these things, these little tricks can help you eat a little more even if you have nausea. After eating, we always tell patients don't lay down. Stay up, let the food go down with gravity. Yes, the GI system is autonomous. It doesn't depend on gravity. But at the same time, when people have nausea, you don't want the food to be sitting down in the stomach too long, and then patients get gassy and all those things. So make sure that you stay up while the food is going down. Chew on gum, peppermint candies, they're always helpful if it doesn't give you heartburn. Use relaxation techniques, exercises, mindfulness, self relaxation techniques. They're very helpful in kind of calming a person down when they deal with a difficult illness, especially when they have nausea before eating. Don'ts is incorrectly written. The spelling is incorrect. Okay, anyway, so don'ts of nausea management. Um, so eating when nauseated, don't eat. If you're nauseated, hold off for a little bit. Take a pill, and then eat when you are ready to eat when the nausea is better controlled. When you eat while you're nauseated, first of all, you won't be able to tolerate things, and there's a good chance that you may throw up, and that is counterproductive. Foods with strong odors, they never work well. Patients often like bland food, which doesn't smell too much. A lot of people say that food tastes like cardboard. It's like chewing on something that is not enjoyable. So foods with strong odor can produce nausea. So don't cook foods, or if food is being cooked in a certain place, move away from there. So once the food is prepared and it's a little colder, then bring it in front of you so that the fumes don't make you more nauseous. Acidic foods, citrus juices, tomatoes, all those things. Nausea does not go well with that. So don't do that when you're nauseous. Alcoholic beverages, another thing, can worsen nausea. Don't do that when you are nauseous. Fatty, greasy, fried foods, spicy foods, anything that is has a lot of odor. All those things, avoid them. It may not go well when you're nauseous. Hot foods, again, if cold food makes you feel a little better as it goes down, hot food will be the exact opposite. So when you have nausea, warm foods, hot foods, they don't go well often, is what the research has shown. Keeping in a stuffy, warm room, one that has cooking odors, one that is very humid, that may not be very helpful. Again, same rationale that half of the odor leave the food and then eat it. Um, so, what medications do we use to treat nausea? There are The most common one, especially when patients are on chemotherapy, is something called as ondansetron. It comes under the name of Zofran. Many of you may know already what Zofran is. So ondansetron can be used. It can be used a couple of times a day as needed. Some people we tell them that if the nausea after treatments is more, you should take it more regularly if okay with your hematologist. There are certain medications that can react with it. So just ask your hematologist if it's okay after treatment. Use Zofran or ondansetron. Other ones are compazine, metoclopramide, which comes under the name of Reglan. They can be used. You should only use one of them at a time, fluclorazine or metoclopramide, although they can be combined with Zofran. They work through different mechanisms. So in many cases, we combine a couple of medications together to control the nausea. A lot of people, they get nauseous before they come to their treatment because they know that nausea will be worse. They have to sit down. It's annoying. It's stressful. With COVID and everything, people are worried about getting sick. So a lot of people get very stressed and anxious when they come to chemotherapy and they get nauseous. So a little dose of Ativan, lorazepam, that can help calm down the nausea because it is produced by the anxiety and the stress of coming to the cancer center and the driving and going through different routes and everything. It's never fun. And often going back from chemotherapy after you've had a long day, people can be nauseous and lorazepam and all those things can calm you down a little bit. Yeah, can help with the nausea. Antihistamines can work the same way. If you're producing a lot of sputum, if you're coughing a lot, it can produce the cough, which produces vomiting eventually at certain sorts of people. And also it can calm you down, it can sedate you a little bit as you're in stressful condition. And that can be helpful, especially while traveling and everything. It can almost work as for like motion sickness related nausea. Other medications, there are newer ones on the market, olanzapine, which comes under the name of Zyprexa, mirtazapine, which comes as Remeron, and one of the newer ones, relatively newer ones, which is the marijuana analog kind of a medication, which is called donepezil. They're all available and they can be used. These are prescription medications, all of them. So always run it by your hematologist or your palliative care physician as to whether these are options for you or not, or if something else can be tried which is better. But the idea behind the slide is that there are various methods through which we can control nausea. There are different medications. They can be used in combination. They can be used alone. They can be used at different times. So sometimes you need a regimen to manage them, and there are a lot of options available for that. Next symptom, low appetite, right? I mean, a lot of people don't eat. We've already touched on it a little bit with the nausea part of things. So it's important when you talk about low appetite. There's a syndrome which is the Anorexia-Cachexia syndrome, and people mix them up, and that's never right. They are two different things. They can be present together, but they're two different things. Anorexia is actually the act of loss of appetite. It's the lack of interest in food and eating. On the other hand, cachexia is the involuntary loss, more than 5% from baseline, with loss of more muscle than fat. And this is what we see in patients with cancer and lymphomas, that patients lose more muscle mass. Their arms are thinner, their legs are thinner, while they can maintain some of the belly fat. So the idea is that when people have more weight loss from muscle, which is more than 5% of the body weight, we call it cachexia. And most patients who are diagnosed, they lose a lot of weight. And that weight loss is a mixture of both anorexia and the outcome, which is cachexia. And it's very common. Like I said, it's something that by the time the cancer is diagnosed, people have already lost a lot of weight. They're not eating, right? And by the time the treatment starts and the symptoms and everything that starts with it, people even lose more weight. So it affects more than 50% of cancer patients overall. There's no statistic available specifically for lymphoma at this point, but I mean, it's very common and we see this all the time, and many of you can probably relate to it. So if it's so common, it's important to know what the mechanism is, right? What's making you not eat? Is it just your brain? Is it just the fact that you're just unhappy, you're stressed out? And the answer is can be. But the biggest reason here is that there are two little parts in your brain. So this is a cross section of the brain. This is important for you to know where your lack of appetite is coming from. And this is important for caregivers to know as well because they get frustrated. Like, listen, I made your favorite food. Why aren't you eating? What's wrong? I mean, this is something that you love. I spent so much time. I mean, why aren't you eating? So there is a neurochemical reason as to why people don't eat. And that is because when you cut down the section of the brain in the center, right here, as you go vertically down, there are two little areas. One is the lateral hypothalamus, and the other one is the ventromedial hypothalamus. Now, you don't need to know the name, but you need to know that these little place areas, the green one and the red one, they control your hunger and they control your fullness, satiety. So they control how hungry you are and they control how quickly you get full. So let's say what we see in a patient most commonly is that either they're not hungry or they get full too fast or they're present at the same time where they are not hungry and they are always full, right? So it is not because of the fact that a person does not want to eat, but because of the fact that cancers produce certain chemicals. These chemicals go to the blood and go to this part of your brain and turn off the hunger center and turn on the fullness center. So what happens is that you're not hungry, you're always full. So anytime someone says, why aren't you eating? This is the underlying cause that we have known to date with our research at this point. That it's the part of the brain that makes you hungry and the part of the brain that makes you full. And one is turned off and the other one is turned on. So you're never hungry and you're always full. So how do we manage this scenario, which is very difficult and almost becomes a social issue in certain places? So I always say, listen, like nutritionists and dietitians, it's always very important on the first couple of meetings to kind of like after you see your hematologist, lymphoma specialist, you talk about, is there a nutritionist in the system? Is there a nutritionist in your cancer center, in your practice? Is there someone you can refer me to? So that they can send you there and they can tell you what to eat, what not to eat, when to eat, how to eat. And nutritionists are excellent at this, especially the nutritionists that focus on cancer-related anorexia and cachexia. They are excellent and they can give you a lot of good advice. Like I said, frequent small meals and snacks, they are always good. Focus more on calories than healthy foods. One of the things that I notice is a lot of people feel that cancer feeds on sugars. Yes, it does. But the fact is that cancers are produced often when people have high sugar diets. Cancer can feed on any body resource. It feeds through the muscles, right? So the idea is that instead of going all natural, going all vegetables, which have no calories, the idea is to have a more balanced diet. The idea is to have more calories. A person needs about 2,500 calories per day. So anything that you like, you can have it. Unless diabetes or blood pressure precludes it, you can have things that are okay to eat, are part of natural balanced diet through the day. So focus more on calories and the magic number that people need to hit is about 2,400 to 2,500 calories per day. If you do not hit that amount, what will happen is that you will start losing weight because once the calories are not covered that the body requires, the body starts going to the muscle, using the resources from within the body, the catabolism, the breaking down of the muscle that starts taking place. That is very important that you eat things that at least go up to 2,500 calories a day to maintain your body. Another thing is to augment meals with milkshakes and ice cream. Now, these things are different for everyone. If you're diabetic, if you have hypertension, if you have cardiac issues, talk to your cardiologist. Say, listen, I'm losing a lot of weight. Can I have a milkshake in a day? Now, why are we recommending this? The idea behind this is that these things have a lot of calories in a little volume, which is easy to dump down and sip and drink, right? You can get about 300, 400 calories. That's why all these things that Ensures and Glucernas and everything else that is in the market, the boosts, right? Brands that are there, they they make it simpler. They make this big a bottle have 300 calories or more. And the idea is that if a person can drink that, that's 300 calories. You have three of those cans a day. You've got 900 calories. That's almost a third of what you need in a day, more than a third, right? So the idea is milkshakes and ice creams and all those things, high calorie things in a small volume can give you that extra push into the calories that you need in a day. There are things like calorie calculators. I mean, you can do that. There are apps. Use them. See how much you're eating. and that can be very helpful. So, what medications are there to improve appetite? Excuse me. Mirtazapine. We talked about it earlier. It can, in certain people, improve appetite. Uh, Prior data, research data that we had showed it to be a much stronger appetite stimulant. Now it's not as good, but it's there as an option. Not really awesome, but can be a good start for patients who cannot sleep, who are dealing with a lot of stress, are depressed at times. Mirtazapine can be that one medication that can hit all three needs for sleep, mood issues, and appetite. Steroids are another one. In lymphoma, it can be a little tricky because they can make you immunocompromised. So always, whenever I start a patient on steroids for appetite, I always run it by the hematologist. Is it okay? If you're on a clinical trial, is that okay to use a steroid? Make sure that your oncologist, your hematologist, your research team, your trial team, we all know about steroids. Another medication that actually helps the most is called megestrol. Some of you may have heard it. It comes under the name of Megace. This medication is very helpful with increasing appetite. But the problem with this is that it can cause blood clots. So a lot of people need to be on blood thinners, and patients with lymphomas who already have low counts on platelets and white counts, and they go up and down all the time, right? The blood counts are different at different times. So it can be very tricky. But this is one of those medications which carries this risk of increased clotting in cancer patients, but yet can be helpful in a patient who's losing a lot of it. Marijuana supplement, another big one. This is the second time we're talking about marijuana. And the answer to that is that if first couple of lines of medications have not helped, then marijuana supplements should be tried. It can be Marinol, something like Dronabinol, the drug that we talked about earlier for nausea. It can be medical marijuana through your state program, if your state allows it. It can be through other gummies or different things that the state allows. You can use that. A lot of people ask me, can I smoke marijuana that is available on the street? And I usually say no. And the answer to that is obviously there are the legal repercussions of things. But then there's also the fact that you don't know where things are coming from. You are immunocompromised. You do not want to risk an infection, smoking things whose purity you're not sure about. These fumes directly go into the lungs, and they can cause a lot of damage, pneumonias and things. And I usually strongly recommend it. Another thing, Arnold Schwarzenegger medications, things like steroids that athletes use to build muscle and like look all bulky and like all huge, they can be used. But at the same time, there are a lot of side effects. They can increase the muscle, but once you stop them, the muscle mass and all those things go away. There are options. Are there long-term options? And the answer is no. So going to a nutritionist, I would say, is among these recommendations probably one of the most important things that you can do. I'll move on to the next issue that we see very commonly is anxiety or stress. And in patients with lymphoma, the most common causes that we see are the fear of cancer treatment or the fear of treatment related side effects, such as pain, change to body image, changes to the body structure, or the inability to do certain normal everyday activities. And that causes a lot of stress. And that is very rational. That is very correct. If a person has been in good shape throughout their life, as they go through this regressive process of cancer, it can be very stressful. So it is very understandable and reasonable that patients go through all this stress. And the sad part is it's often overlooked. People tell you to be strong. People tell you to be look beyond certain things. But you have to realize that these things have to be recognized and they need to be treated for a good outcome. A lot of people, even when they are better, when they are cancer free, they have this constant fear of the cancer returning or spreading after the treatment. There's this sense of uncertainty as to are the treatments going to work, are they not going to work. There's always a worry about losing one's independence, concerns about relationship changes, and the ultimate fear of death. These are very real fears. We see this all the time from our patients. And it is very important to recognize them, bring them up, talk to your oncologist, talk to your hematologist, get someone to talk about these symptoms, psychologists, psychiatrists. There's no shame in that because these are very reasonable and rational fears. And bringing them up and treating them will definitely improve the outcomes of your treatment. There can be a lot of medical causes as well. There's a whole laundry list. And anytime you talk about these things with your hematologist, they will probably do a couple of tests as well. Again, like anything, treatments are different based on how long this anxiety has been. If it's like something that is very acute, something very new, the treatment should be different. If it's something that is chronic, the treatments are going to be different. They're going to offer different treatments for it. And sometimes it's acute on chronic, where someone has always lived with a little bit of anxiety, but that was manageable. But then all of a sudden, this cancer thing grew, and the anxiety just peaked. It just went totally out of control. So acute on chronic. So they require certain medication. Why is this important? Again, from a patient's perspective, is because the oncologist or the hematologist or the psychiatrist or the palliative care person would offer different treatments for it. So number one, self-management is probably one of the best things one can do. It's most easily available. It's yourself that is treating it. Mindfulness, guided meditation, relaxation techniques, all these things, they have shown an immense benefit in patients who are going through a constant anxiety-related issue. Sometimes deep breathing. Remember when we have patients, little kids, not patients, little kids who are yelling and screaming and throwing a tantrum, we just tell them to take deep breaths and kind of relax themselves. That's exactly what it is, right? It relaxes things. It puts the mind at ease, improves the oxygen circulation, increases the blood flow, right? So that is the best thing. Now, from a medication standpoint, if it's acute anxiety, things like Ativan, Klonopin, clonazepam, Buspirone, all those things can be. But acute anxiety is short-lived. You always need a long-term plan, right? For that, you need to use things like SSRIs, selective serotonin reuptake inhibitors, or SNRIs, which are selective serotonin norepinephrine reuptake inhibitors. In short, medications like Paxil, Prozac, Zoloft, sertraline, paroxetine, fluoxetine, Lexapro, citalopram, all those things, these fall in that category. And they can provide a long-term benefit, for especially with the patient with lymphoma, who has the ups and downs and a constant presence of disease or the treatment or the worry. It can be probably the game changer in a lot of patients. We always refer to specialists when things are more complex. If a patient has long-term anxiety, long-term worries related to their illness, if they have suicidal ideation, if they have homicidal ideation, if they have things that are pathological in their origin, things that can be dangerous to others or themselves, then we always recommend specialist psychiatric care. And it's always better to get it earlier, sooner rather than later than trying certain medications. So I would say that be very vocal about your symptoms. And if you feel certain things that are not normal, ask your doctor to make a referral. That can be literally life-saving in certain cases. So management of anxiety support systems, spirituality, behavioral therapy, as we talked about, all these things are really helpful. Your cancer centers, your clinics, your oncologist or hematologist has resources and available resources to social workers, support groups, excellent national organizations like LRF, Lymphoma Foundation, that we are working under at this point. These organizations, these support groups, these social workers can provide a lot of resources. They can be the first line of therapy for a lot of patients. So use these support systems. They're available. Ask for them. So going to the next symptom, this is depression. Again, very commonly seen, often bundled with anxiety. People just don't have anxiety or just don't have depression. It's always, in most cases, a mixture. So depression causes a lot of them, the same causes: worries, stressors of life, work, finances, inability to sleep. Um, all those things cause it, right? The same thing that we went through for anxiety. There can be medical causes, obviously, but usually as you're going through treatment, you'll have a lot of stressors, you'll have a lot of worries, family issues, and they can cause a lot of depression. Sometimes the medication that you're on for chemotherapy, that can also cause you to be stressed and depressed and have anxiety and worries, and that can cause it. And like I said, relationship anxiety is very common. It's usually rare to find anxiety or depression in isolation. Usually they are in combination. So you have to work on both. So if someone is feeling depressed, what are the warning signs? What are the things that you should seek urgent help for? And the answer is if you're getting suicidal or homicidal thoughts, if you are having a significant functional decline because of depression, you are not going out of the house, you're not taking showers, you're not changing clothes, you are not able to maintain your personal relationships, all those things that go into a functional life, everyday life, and it's seriously impacting you, you should talk to a specialist. That's a warning. Substance abuse issue, prior or current, they're always considered to be a high risk thing for depression. Very dense symptoms. Depression, which is not letting you out of bed every day. You don't want to wake up. You just stay in the bed all day long, right? You're fatigued. You don't want to eat. You don't want to talk to people. If the symptoms are very dense, this is again sign of a very bad depression, very dense depression. This requires urgent referral to a psychiatrist or someone who's specialist who can start managing. Again, if someone has admission history for psychiatric reasons, that's another reason that we take very seriously. If someone was admitted for something, probably for something very serious. And in those cases, we usually consider that a warning sign. Again, what are the treatments? SSRIs. These are the medications that we have talked about. Long-term chronic anxiety medication, which are things like paroxetine, fluoxetine, Zoloft, Lexapro, escitalopram. I mean, the list is growing every day. Um, these are all there, Paxils, Prozacs. They can be used and they can work both for anxiety and depression. There are other medications called BPAs, which are tricyclic antidepressants like amitriptyline, old school nortriptyline. So the idea is there are tons of medications that continue to come into the market. So going to an expert, going to someone who does this for a living may add a lot of value. Uh, Finding these things early, focusing on these symptoms early, will, like anxiety, will have a better outcome if you recognize the symptoms earlier. Again, go to support systems, spiritual resources, behavioral health resources, social work, support groups, organizations. Because anxiety and depression are bundled almost together in most cases, if you hit one, you probably get both. So the same resources are available. Last one, insomnia, something that we see very commonly. Patients don't sleep. They are sleeping during the daytime, they don't sleep at night. So there are a couple of things that you should know. Causes of insomnia. If someone is using steroids, certain chemotherapies, certain medications, that can cause a lot of insomnia. So run it by your hematologist as to what these symptoms are and if they're caused by medication. Depression, anxiety, they can do that. Um, these are the 5 rules that I live by for sleep hygiene for my patients. I always tell them that you have to follow these 5 things as the first line. And first thing is lie down to sleep only when feeling sleepy. Don't go to bed without a reason. Avoid wakeful activities in bed. I mean, we all love to use our cell phones and our iPads and watch TV and all that. Don't do those activities. Don't read books. Don't do all those things. They will make you more alert and you will waste your time in bed while doing these wakeful activities. Maintain a consistent sleep-wake cycle. Don't go to bed in the daytime. Sleep at night. Make it a thing that I will not sleep more than 15, 20 minutes in the day, even if I really, really want to. A little nap may be okay, but you should always make sure that you are sleeping at a regular time, waking up at a regular time. Set the alarm for the same time each morning. A lot of older patients and patients who are getting chemotherapy on certain days, especially if it's late, um, avoid water intake prior to sleep. I usually tell my patients that 3 hours before going to bed, start cutting down. If you wake up at night, it's first of all, it destroys your sleep. You may not be able to go back to sleep. Secondly, I mean, a lot of people can fall when they go to bed. If they're sleepy, they're taking certain medications, they fall, they can slip, they go to toilet, it's ceramic all around, they'll break something. So water intake restriction is usually helpful. Medications, things like over-the-counter medications like melatonin and all those things are really helpful as first line. They can fix the sleep cycle, circadian rhythms as well. Then things like zolpidem that comes under the name of Ambien that can be helpful. There are antipsychotic medications, trazodone, Seroquel, all those things, quetiapine, they're available. Then there are specialist medications that psychiatrists and sleep specialists use. So there's a lot of variety available for patients who are having difficulty. But trying the behavioral approach, the sleep hygiene approach, and then melatonin are the first couple kinds of management that we offer. I always say that benzodiazepine things like Xanaxes and Atimans and Clomidine are not good because after a little while people get number one a dependency on them for the fact that I mean if they don't take it they start getting withdrawal. And the second thing is that after a little while people get tolerant. So let's say a half a tablet of Ativan is working for you really well. After a little while, that won't work. You'll do one, then you'll do one and a half, then two, and you'll increase the dose. Then it won't work at all. So people get tolerant to these medications, and it's not prudent to use them for long term for sleep. Fatigue, lots of causes: anxiety, cancer, anemia, malnutrition. You can go through this. We usually say fix the underlying cause, motivate a patient, go active, become more present. Exercise, improve the diet, all those things, it's really important. Medications can be used like caffeinated supplements, steroids, anabolic steroids, again, short-term answers, long-term, they're not great. Amphetamines, things like Ritalin um, and all those other medications from the same class, methylphenidates, they can be used. Um, and always ask for palliative care. This is the final slide, I think. And the idea is that palliative care is a specialized care for people living with a serious illness that is focused on providing relief from the symptoms and stress of illness. Palliative care focuses on all these symptoms that we've talked about. This is their bread and butter. Their goal is to improve the quality of life both for the patient and the family. And they are pretty widespread now. Any state you go to, any big cancer center, there are palliative care specialists. Ask your hematologist or oncologist to talk about them. And a lot of misnomers about palliative care and hospice. Palliative care is not the same as hospice. It's completely different. They are in transition, but they are completely different things. Don't mistake one for the other. It's based on the needs of the patient, not on the patient's prognosis. Patients live on palliative care for years and decades. It is appropriate at any age and at any stage in a serious illness. So, and it can be provided with a curative treatment to provide an extra level of care support for everyone. So, ask your hematologist, your oncologist, your care provider if you can get a referral. Following up with them will improve your symptoms. We've seen that in a lot of cancers, including blood cancers, and that can improve the outcomes and the quality of life for the patients.